Welcome to the blog session of the Center for Podiatric Education. One of the lectures available at this site is an update on the current status of thromboembolism disease prophylaxis in foot and ankle surgery. And to summarize that lecture, we know that the literature would indicate a very low incidence of DVT and pulmonary embolism associated with foot and ankle surgery. And we know that generally papers suggest that DVT prophylaxis is not indicated or required for foot and ankle surgery. However, the majority of these papers typically hedge their bet, if you will, and say, however, each patient must be evaluated and assessed individually and risk stratified individually. We get no further guidelines beyond that. And when a patient sustains a major thromboembolic event leading to severe venous disease or cardiopulmonary disease or death, it's very easy for someone to look back in hindsight and say, I would have prophylaxed this patient. And one of the difficult questions to deal with is that one knows the weight of the literature states prophylaxis is not indicated, but sitting in a deposition or a courtroom and having an attorney say to you, well, doctor, had you prophylaxed this patient, is there a chance they would be alive today? And while we can point out that even patients properly prophylaxed do still sustain pulmonary emboli, that prophylaxis does not provide absolute protection but statistical protection. And while we can point out that patients can have complications from prophylaxis, it's a difficult question to answer when you're saying, yes, I suppose if I had prophylaxed that patient, there's a much greater likelihood that they would have not sustained a significant cardiopulmonary event or death. And I could also see the converse, by the way, where a patient, for example, sustains a significant GI bleed or ophthalmic bleed or intracranial bleed and sustains damage because of that, or sustains some renal problems, and having a plaintiff's attorney sitting there going, well, doctor, the literature suggests that this patient really didn't require prophylactic anticoagulation, and your unnecessary use of these medications resulted in injury to my patient. It's a situation where you're damned if you do and you're damned if you don't. So I thought I would review with you some of the cases I have been involved in over my 40 years, just to let you know the reality of these things. So the first case was that of a young woman of German extraction married to an American GI here in Missouri. And she consulted a podiatrist with a black spot on the dorsal medial aspect of her hallux interphalangeal joint. The podiatrist alertly was concerned about the possibility of a melanoma. He did a punch biopsy, and indeed, he made a great diagnosis, and the patient was diagnosed as having a melanoma in situ, and according to the pathologist, the entire lesion was excised with the biopsy. However, although the margins were clear, the pathologist recommended that the podiatrist go back and just take a wider excision just for safety's sake. So he took the patient back to the operating room, used an ankle tourniquet, and did an elliptical excision of the skin about the biopsy site under local anesthesia. And he advised the patient to cut back a bit on how much walking she typically would do, because he was concerned about scarring as the incision crossed the interphalangeal joint. gave her a surgical shoe, and she left. About 10 days later, she called the podiatrist, telling him that she had a strange thing happen. As she was walking up her stairs, she had a rapid heart rate and became a bit dizzy and sweaty, and this lasted for about a minute, but now she was fine. Now this was a woman who is young and healthy, under care for no medical problems, and the podiatrist said, listen, if this happens again, I'd recommend that you go to a local emergency room. And he questioned the patient, and she was taking a cold remedy that did have the potential to have caused these symptoms. 2 days later, she died of a massive pulmonary embolism. Now, the family and husband brought litigation against the podiatrist. And keep in mind, this was a patient who had an elliptical excision of skin over a hallux interphalangeal joint. The patient was taking Yasmin, and Yasmin is well known, and anyone who watches late night TV has seen the commercials, that Yasmin can be associated with pulmonary embolic disease and death. But they were able to find a podiatrist who was willing to testify that this patient was at high risk for DVT and pulmonary embolism for the following reasons. The podiatrist testified that, number one, Yasmin is known to be associated with DVT and pulmonary embolism, and that it should have been discontinued at least 2 weeks prior to surgery. And indeed, the PDR does have a black box warning suggesting that Yasmin should be discontinued, quote, prior to elective surgery, close quote. They also argued that she had cancer, although this was an in situ minute melanoma that had been excised previously. And when we talk about malignancies and DVT, I think anyone would tell you you're talking about larger tumors that are producing procoagulant substances, or tumors compressing perhaps a major vein, a vena cava, whatever, and certainly not an in situ melanoma that had been excised a month before. Nevertheless, the plaintiff's expert said, well, she was taking Yasmin, she was under care for a cancer, she was relatively immobilized, even though she was up and walking quite a bit. He said, no, her normal routine was off. They also argued that since she was of German extraction, there was a chance that she had factor V Leiden mutation, although this had never been diagnosed in her family, and she had certainly never had any episodes of DVT or pulmonary emboli. They also argued that a tourniquet had been utilized at the ankle, and that tourniquets were associated with increased risk of DVT, which we know is not supported in the literature. I felt comfortable as the defense expert that we would prevail in this case. However, it resulted in a settlement, because it is very difficult to win a case when you have a patient who's died of a pulmonary emboli, and you have a plaintiff's expert who's willing to go in front of a jury and state that for an ellipse of the skin, the Yasmin should have been discontinued, that she was relatively immobilized, that she had a malignancy, that a tourniquet was utilized. And so all these factors adding up sounded or potentially convincing to a jury of people without really detailed knowledge of the literature regarding DVT and pulmonary embolism. So the case was settled. It was settled for quite a few $100,000. I might say, as an aside, over my objection. My first introduction to DVT cases was actually an Austen bunionectomy in a healthy 50-year-old male. This was a patient who was seen by a podiatrist diagnosed with a limitation of ankle joint dorsiflexion and a an Austin and a bunion for which an Austin was going to be performed. The limitation of ankle joint dorsiflexion was well documented, and the patient had a symptomatic bunion. He was a healthy male, and the patient had no known hypercoagulable states, no venous insufficiency, no predisposing factors to DVT. He underwent an Austin bunionectomy with tourniquet hemostasis. About 2 weeks following surgery, he presented to the podiatrist and was wearing a posterior splint. In those days, Austins were often protected by splinting, and he had some pain in his calf. The podiatrist documented a very detailed examination. He detailed a negative Homan, a negative Pratt. He documented the absence of any swelling or temperature changes. He documented that the patient was stable, no excessive sweating, no tachypnea, no tachycardia, no chest pain, no symptoms at all, and attributed the calf pain to the fact that the patient had a previously diagnosed limitation of ankle joint dorsiflexion, which was documented in the chart, and was being held at a right angle in the splint. So the splint was removed, and the podiatrist massaged the leg a bit and dorsiflexed the foot, and the patient actually felt better when the leg was dorsiflexed. So the patient was discharged, and about 2 or 3 days later went to an emergency room with chest pain. The emergency room physicians noted that the patient had undergone a bunion procedure, that his leg had been splinted, that he had some pain in his leg, and that he had chest pain. An EKG was negative, workup for cardiac enzymes and so forth was negative, and a diagnosis was made of pulmonary emboli. Before any anticoagulation was given, the emergency room doctors notified the primary care doctor, who said, well, why don't you hold off until I get there. The primary care doctor then arrived, examined the patient, and agreed that the cardiac workup was negative, that the patient had likely a pulmonary embolism, and a VQ scan was actually performed, which indeed showed several small pulmonary emboli. The primary care physician determined that perhaps the best approach would be lysis of the clots, and consulted with a vascular surgeon to come in and examine the patient and determine whether heparin alone would be sufficient, or whether or not clot lysis would be appropriate. The vascular surgeon arrived in the afternoon, examined the patient, and agreed that the patient would be a good candidate for clot lysis, but the vascular surgeon was uncomfortable with the patient receiving both an anticoagulant and streptokinase in the emergency department, and said, let's transfer the patient to the ICU, and then we'll initiate the clot lysis. The patient was transferred to the ICU and was stable, alert, and no distress, and was sitting in his bed eating a tuna fish sandwich, as I understand it, watching the Johnny Carson show, and then sustained a major saddle embolus and died. And it was a terrible situation, and as I understand it, the podiatrist was actually staying at bedside with the patient through this whole situation, and was present when the patient died. The suit was against the podiatrist for failing to immediately refer the patient for anticoagulation and for appropriate testing, when he first presented to the podiatrist's office with pain in the calf, absent any other signs or symptoms of DVT, and in fact, the records were very, very well documented. Here again, the plaintiff was able to obtain a plaintiff's expert who testified that he would have immediately started heparin therapy and would have immediately obtained appropriate diagnostic studies, and had that been done, the patient would still be alive. As I mentioned, this was my first go-round with prophylaxis or the potential need for prophylaxis in a patient undergoing foot and ankle surgery. Here again, the case was settled for quite a bit of money as we had a deceased patient. Another case with which I served as a defense expert is that of a patient with factor V latent mutation history. This was an interesting case to me personally. The podiatrist was a well-established podiatrist here in this country, state board member, very respected. Patient presented to the podiatrist and was worked up and found to have a tarsal tunnel. And the patient gave the doctor a history of factor V latent mutation. The podiatrist then referred the patient back to the primary care doctor, requesting the information regarding DVT prophylaxis. I don't know where the primary came up with this, but the primary sent a note back to the podiatric physician saying, I would probably have this patient prophylaxed for 10 days. I don't know the basis of that, but that was the recommendation. The patient underwent a tarsal tunnel decompression and then sustained several days later a massive pulmonary embolization. Now, the patient did not die, but was left with very serious pulmonary compromise and sued the podiatrist. It turned out that the patient never received any prophylaxis. The podiatrist stated that it was their impression that the primary care doctor would be providing the necessary prophylaxis. The primary care doctor said, no, this was my recommendation for the podiatrist to follow. In any event, the patient did not receive any prophylaxis whatsoever. We argued that perhaps the patient was heterozygous rather than homozygous, but here again, given the circumstances, there was a rather large settlement tendered in this case. The fourth case I'd like to present to you was a patient who had posterior tibial tendon dysfunction, underwent a calcaneal osteotomy and repair of the posterior tibial tendon, and was placed in a cast. About 48 hours after surgery on a Friday evening, the patient's wife called the podiatric surgeon to state that the patient was experiencing very severe swelling in the leg, and the swelling was in fact going over the end of the cast. For whatever reason, the podiatrist didn't seem to be too excited about this and just said, well, if you're really worried about it, bring the patient in on Monday. You might elevate the leg a little bit, but other than that, we're not particularly concerned. The wife was very concerned about the extent of the swelling, went ahead and actually removed the cast herself. I don't know why they didn't go to an emergency room when they did not, but the patient through a major pulmonary embolus and died. And the post-mortem showed that clearly the clot had emanated from that leg. The patient sued for not reacting to the phone call and directing the patient either to the emergency room or to the office for immediate removal or at least inspection of the cast and the leg. The podiatrist then went back to the hospital and redictated an operative note and altered the record by adding to the newly dictated note the fact that he had directed the patient to utilize aspirin prophylaxis. And unfortunately, this was not consistent with the initial operative note. It made the case very difficult to defend, and a large settlement was tendered. The next two cases involved fractures. One was a peritoneal stress fracture, a patient with heel pain. Patient had a family history of blood clotting. The patient was initially treated for what seemingly was plantar fasciitis, did not improve. Repeat x-rays suggested a stress fracture. The repeat x-rays were taken because the leg was swelling, as was the heel and foot. There was quite a bit of pain on compression. The patient was placed in a cast, and unfortunately the patient threw a massive pulmonary embolus and died. A suit was filed. The medical records clearly documented the patient's relaying a history of DVT in the family, and the fact that the patient was not considered for prophylaxis, and here again the case was settled for a substantial amount of money. We had occasion to see a patient in my office. I received a phone call from an area podiatrist, a nice fellow, who had a patient that sustained fractures of the second, third, and fourth metatarsals, and they were pinned. Unfortunately, the pinning did not go that well, and the fractures were missed by the Kirschner wires. The doctor was calling me to find out if I would assist him in repositioning the fixation, and I said I certainly would. I'm always willing to assist people in the operating room, and I've never charged anybody for that. But I do have one rule, and that rule is that if I am at all uncomfortable, I would like to see the patient in the office prior to agreeing to assist anyone in any procedure, just so that I'm comfortable. I saw the patient in the office, and I noted her leg was rather warm and swollen, and I was checking her leg, doing a Homan and Pratt, which were positive. And the patient said to me, "Are you looking for a blood clot?" And I said, as a matter of fact, yes, I'm very concerned. Your leg is warm and swollen and tender. And she said, "Please don't make me get another one of those Doppler studies." And I asked her what she was talking about, and she said she's always had this warm, swollen leg, and people always think she's got phlebitis, and she's never been diagnosed with phlebitis, and she's had several Doppler studies over time, and she was really reluctant, as was her husband, to even consider a DVT. The surgery was scheduled actually for the next afternoon, the following afternoon, and I was concerned about her leg, and I said, "Listen, just do me a favor." I said, "There's a hospital right down the street from the surgery center, and your surgery's scheduled for tomorrow afternoon. Just to make me feel better, why don't we just go ahead and get a Doppler just to be safe?" And she was agreeable to that. I went to the hospital that morning to make rounds on some patients, and as I was walking by radiology, one of the radiology techs came out to grab me, and the radiologist asked if this was my patient, and I said yes. They said, well, they were on their way taking her to for a CT with contrast, and she was throwing pulmonary emboli as we were speaking. We got her admitted to the hospital, and she was stabilized, sustained no permanent damage. That night I was making rounds in the hospital, and she thanked me for making the diagnosis. The hospitalist was kind enough to say that I had, quote, saved her life, close quote. Actually, it was quite the opposite, and my wife was very quick to point it out to me. She said, you know, you saw that patient yesterday, and you suspected a blood clot and DVT, and I was surprised that you didn't send her for an immediate Doppler and D-dimer. She said, what would have happened if that woman had died of a pulmonary embolism that evening? You, meaning me, would have absorbed that liability. And she was right. So just a lesson to be learned there. I was very, very fortunate, and more importantly, the patient was very fortunate. But if you suspect a DVT, it's important to act quickly. The next case is that of a patient who underwent a tarsal tunnel decompression. The patient then was to follow up in the office. The doctor who did the tarsal tunnel decompression went on vacation. The patient called with swelling in the leg, and swelling of the foot, with pain in the leg. The podiatrist covering for the vacationing podiatrist said, well, why don't you go ahead and go to the emergency room and have them check. The patient did not do so. The patient then returned about 2 weeks later to see the podiatrist who had done the original surgery. The podiatrist who had done the original surgery queried as to whether or not the patient had gone to the emergency room, and the patient said, no, I didn't. I feel better now. The podiatrist, seeing the patient on this occasion, did not redirect the patient back to the operating room, but rather said, fine, I'm glad you did okay, and redressed the patient after removing sutures. And unfortunately, the patient then threw a pulmonary embolism and died. At autopsy, the clot in the leg confirmed the origin of the pulmonary embolism, and the case settled rather quickly, as there was no problem finding a plaintiff's expert who was more than willing to testify that the patient should have been immediately redirected back to the emergency room. The next case is that of a patient who was weighing in at well over 500 pounds. The patient was being considered for bariatric surgery. Obviously was morbidly obese. The patient consulted a podiatrist with a bunion that was determined to require an Austin bunionectomy. The Austin bunionectomy was performed with tourniquet, and following surgery, the patient sustained a massive pulmonary embolism and died. Plaintiff's expert contested that because the patient was massively obese and because a tourniquet was utilized, that prophylaxis should have been initiated. And here again, the case settled for a reasonably substantial amount of money. Lastly, is a case where you have to wonder what somebody is thinking. A patient presented to a podiatric physician in need of a talonavicular arthrodesis. The patient informed the podiatric surgeon that both his father and brother, quote, died of blood clots, close quote, period. The podiatrist actually noted this history. The patient was not referred for any type of workup for any hypercoagulable state. The patient was not provided any type of DVT prophylaxis. the patient died of a pulmonary embolism, as did his father and brother. Obviously, this case settled rather quickly for a substantial amount of money. I think you also want to remember that these patients going to the hospital now and certain surgery centers are being evaluated by nursing with these thrombosis risk factor assessments, and oftentimes they achieve scores that would imply the need for DVT prophylaxis, even though they are patients that you normally would never think to prophylax. And I think this puts us in a bad position when they start checking off all these things. For example, the patient might be older than 60. They may be in an immobilizing cast. They're having surgery that lasts greater than 45 minutes. They're overweight. They may have some varicose veins. And before you know it, you start adding up all these factors, and these patients are at significant risk. And we get back to this concept of DVT prophylaxis is not required for foot surgery unless they're a high-risk patient. And we don't have a definition for high risk, and the next thing you know, you have a plaintiff's expert and a plaintiff's attorney waving this thrombosis risk factor assessment sheet in your face saying, well, doctor, you know, the nurses did an evaluation of this patient. In fact, you signed off on this sheet showing us that the patient had a score such that they were at risk for DVT. So we have to deal with this reality, and these are the realities we have to deal with, that we know that the incidence of thromboembolic disease in foot and ankle surgery is extremely low, but that does not absolutely protect the patient. And we know that recommendations are made to prophylax patients who are, quote, high risk, close quote, but we have no definition of what that means. We also know that DVT prophylaxis can result in significant complications. There can be local complications such as wound bleeding, infection, drainage, wound healing complications. There can be serious bleeding complications involving the GI tract, intraocular, intracranial. We can have drug interactions in patients taking other medications. We may be unnecessarily increasing the cost of care. And we know that in summary, we have a total lack of consensus for what constitutes a high-risk patient needing prophylaxis, except that in hindsight, plaintiff experts can always tell you that the patient that did sustain a thromboembolic event should have been prophylaxed. So these are the realities that we have to deal with, and I thought I would share with you some of the lawsuits I have been involved in and one near lawsuit in order to give you something to think about with regard to DVT prophylaxis. I hope this blog's been helpful to you.